visible?
Yes, sir, it is visible.
Yeah, okay, fine. So I have started recording also so that we can access it on a later date. Okay, so coming to the first session, I'm very happy I'm taking the first session. Usually it is Pulsar, but unfortunately, sir couldn't join. So we'll start off the preparation of our IST BGDMT program with starting discussing on the general management of poisoning. So general management of poisoning, as I'll be covering basic introduction, the initial ABCD approach, which majority of you will be aware of, and specific drugs and toxin causing changes in the vital parameters. So that is the most important aspect that we need to discuss here. And the next week, we will have the toxidrome approach, how we need to deal with each type of poisoning. So that will be the toxidromic approach. Then we will discuss the specific decontamination. What and what are the challenges that we have in various decontamination procedures and the various elimination techniques. So that will be my session to start off. So as we all be aware of, the systemic and consistent approach to evaluation and management of a poison victim is the key. So majority of the time there will be associated medical problems. So that is the biggest challenge as we doctors face in managing toxicology cases. It will not be just the poisoning. He will be having other comorbidities, so over that, he would have consumed whichever the poison be, and the presentation will vary from person to person. And also, it will not be a single poison, it will be multiple ingestion. There can be associated co-ingestion, maybe alcohol being one of the common co-ingestion along with the majority of the poison that we see. And the list of chronic medications they are already on, and the chronic medical issues that they will be already on. And initial management pattern, as we always discuss, it is the ABCD, the classical ABCD approach, and a focus history and physical examination. So, from the focused history and physical examination, as an emergency physician, what we usually say is that whenever you get a patient, you are unable to get any clue, always keep toxicological differential diagnosis, toxicology causes as one of your differential diagnosis. So, majority of the time, we will be dealing a lot of sepsis, some cardiac failure, or other things, but some presentation, you will not be able to fix it in a specific organ system involved. It will be having multiple areas of involvement and it would have a specific pattern sometimes. So if you are getting those things, always keep toxicology as one of the toxicological causes as one of your differential diagnostics depending upon your patient presentation. Basically, the management is directed. Majority of the time, it is supportive. We all know how much we can do for the poison victim. So majority of the time, it is a proper supportive care. I will put it that in inverted comma, and prevention of further poison absorption, and when applicable, the use of antidote. So my colleague Dr. Shabrish will be giving you in detail regarding antidotes and how much we have in our hand, because only less than 10% of the poisons will have got an antidote. Rest we don't have. So majority of the time, we just need to manage them symptomatically by doing our ABCD approach and requiring as required dialysis. All those things is what is there in our hand. So meticulous supportive care is the paramount. As an individual alone, you cannot do. You need your support from your colleagues from various departments. So you need to have a team for this, managing any of the toxicology victim like for any other patient. So initial examination. So a brief initial screening examination. That's what I suggested initially. Assess the airway, the vital sign, the mental status. Very important. Don't miss the pupil size, the skin temperature, and the moisture. So the pupil size usually in an emergency room when you have got a patient in altered sensorium or a head trauma, we used to examine. But always keep that sign. Pupillary examination is very important whenever you get a toxicological victim or you suspect any of the patient that is coming to the ER with probable toxicological causes as the presentation to the emergency room. So majority of the time, the immediate diagnostic study to be performed include a simple pulse oximetry where you're having a patient with methemoglobinemia. Pulse oximetry can give you a clue, and additional continuous cardiac monitoring, an electrocardiogram, capillary glucose measurement, very, very important. So a simple glucose random blood sugar, which is what is more necessary sometimes that because the toxin would have causes a hypoglycemia, and IV access should be obtained in all cases of serious ingestion. So that we all do, but just for the general aspects, I need to cover all those things. So assessing the patient condition, correct problems of ABCD, that is the most priority, airway, breathing, circulation, and depression of CNS. So these are the four important areas that we need to cover. most respiratory and cardiovascular status, the normal vital signs, including your blood gas analysis with a co-oximetry is very important. Respiratory pattern, again, we know the respiratory rate, but we don't look at the respiratory pattern, capillary refilling time, heart rate, blood pressure, and urinary output. All these things are really key in any of your toxicological victims. And management of the airway. So assessment of patient's condition, management of respiratory failure, including clearing the airway, positioning the patient properly, applying an oropharyngeal airway, aspirating the secretions, and putting a cuffed endotracheal intubation. These are all very, very important aspects. So when you come for the offline training session, those who are wind, because I know in those who are in the emergency medicine background, they will definitely have an idea. But what this program is intended, at the end of 1 year, everyone should have basic airway management, basic ECG knowledge, basic simulation based training regarding to toxicology has to be done. So you don't worry, those who are not very well versed with these techniques, you will be taught while you're coming for the offline session. And you might be having an additional offline training also for those who are interested. Some candidates, they say that they wanted an additional offline training, so we will be planning that also during the end of 1 year. So before your final exam. So also that will be arranged for you for those who are requesting. So some people we wanted to come for one more day and we just need to learn everything before our final exam. So definitely we can arrange that also. Coming to the breathing, supplementing oxygen, very important to remember the uses of non-invasive ventilation, high flow nasal cannula, and mechanical ventilation, like we do for any other patients. And management of circulatory failure, IV crystalloid, acidemia correction, very, very important. Majority of the toxin, there will be an associated acidemia that is causing the hypotension. So the role of bicarbonate will come, where to give bicarbonate, when not to give bicarbonate, all those things we will discussing in today's antidote lecture. So acidemia correction, very important. So keep in your mind that whenever a toxicology victim is not improving, acidemia can be one of the reason the blood pressure is not improving well, and the use of vasopressor depending upon the situation. To assess the level of consciousness, we classically do the Glasgow Coma Scale, but there is something else called as Reed's classification or the Edinburgh method. So this is one that we can use for the comatose patient coming to the ED. So group 0, we have arousable patient. Group 1, respond to painful stimuli, have intact reflexes. Group 2, do not respond to painful stimuli. Most reflexes are normal. Group 3, do not respond to painful stimuli and most reflexes are absent. And group 4, they are deeply comatose with respiratory or circulatory failure. This is one of the classification where we can use for our toxicology victim also. And basically, it's used for comatose patients. This can also be used for our patients coming with toxicological problems. So coming to very important hypothermia and hypothermia management. So management of hypothermia, mild cases, you can go ahead with the warm room or a blanket, or severe cases, you need to go ahead with active rewarming like warm water bath, central core heating. And again, management of hypothermia on the other side, you might need to have a cold water bath or application of ice. So this is the two spectrums that you need to keep in your mind. So majority of the patients can have both these hypothermia, and on the other side, they also can have hypothermia also. So this is the very important chart that I want you to remember. So common drugs that produces changes in the heart rate. We all know tachycardia is caused mainly by alcohol. You remember your datura, salicylates, nicotine, and your sympathomimetic drugs. Any of the sympathomimetic drugs will cause you tachycardia. So this chart, if you're able to recognize well, that will be well and good. And coming on to the other side, common drugs causing bradycardia. Remember regarding your digitalis, opiate, organophosphorus, definitely your beta blockers and calcium channel blocker that you can't miss, and aconite also. So you have got some herbal preparation, specifically in some parts of India, they still have some as an Ayurvedic or an alternative system of medicine, they still use aconite. So that can also cause bradycardia. So you have your beta blockers, calcium channel blockers. On top of that, remember regarding digitalis, opiates, and organophosphate that causes a decrease in the heart rate. So drugs that produce changes in blood pressure, on this side, you are causing hypertension like amphetamines, cocaine, nicotine, phencyclin, and sympathomimetic drugs. And on the other side, you have drugs which cause hypotension, which the commonly one will be the diuretics, ethanol, opiates, sedatives, and hypnotics. So these are the agents that causes changes in your blood pressure. On this side, you have the drugs that cause changes in your urine output. You have oliguria. You can have with barbiturates, carbolic acid, ethylene glycol, oxalic acid, salicylates, and sulfonamide. So what are being given in the drugs are of more importance, and others are also can cause oliguria. is the drugs that I am mentioning. I'm not mentioning regarding the toxins. These are the drugs that cause decreasing in the changes in the urine output. On this side, you can again have hypo and hypothermia. Hypothermia, remember regarding your barbiturates, carbon monoxide, CNS depressant, opiates. On the other side, you have hypothermia, your amphetamines, anticholinergics, cocaine, and salicylates. Pupillary changes, very important. Meiosis, the drugs that can causes meiosis, barbiturates, caffeine, chloral hydrate, nicotine, opiates, organophosphorates. And on the other side, you have mydriasis, which will be caused by, again, with alcohol, amphetamine, carbon monoxide, cocaine, cyanide, and datura. So that is meiosis and mydriasis for you. On coming to the very important, one of the most important, we'll have a separate lecture on acid-base disorder in toxicological cases, but metabolic acidosis. So acetyl salicylic acid, carbolic acid, ethanol, ethylene glycol, isopropanol, methanol, oxalic acid, and sulfonamide. These are the agents that you need to keep in your mind, which causes metabolic acidosis. Coming to the other management aspects, correction of metabolic acidosis, very important by giving soda bicarbonate in toxicology cases. How you need to start, when you will to decide to give soda bicarbonate, very important. You should understand you will have certain specific reasons to start soda bicarbonate, like for a TCA toxicity with a QRS duration more than 100 milliseconds, you will start. But in certain conditions where you have severe metabolic acidosis associated with hyperkalemia, you might need to start on soda bicarbonate infusion, which we'll be discussing in the upcoming lecture. And coming to the convulsion, always remember the drug of choice is benzodiazepine for most of your cases. For most of your cases, with toxicological cases, they are presenting with seizure. Remember, it is benzodiazepine and fluid and electrolyte imbalance correction. So, as I told you, only 10% of the toxins or the drugs that can have antidotes that is available. Rest, they don't have any of these antidotes available. So, very important to understand that supportive management is the key in treating your toxicological victims. And most importantly, coming to the decontamination part. So, as the name implies, it is basically the elimination of the poison. So we will start regarding ice, how to decontaminate the ice if there is any exposure, washing with saline water, what is recommended for, and dermal spillage, you can have to remove the clothing, wash with saline or water. And if the patient has ingested, so we have several decontamination methods starting off with emesis, gastric lavage, whole bowel irrigation, up giving activated charcoal, catharesis, post diuresis, hemodialysis, and hemoperfusion, etc. We will see one by one. So decontamination of the skin. So very important, you are having your self-protection and your co-workers also should be protected well. Remove the patient's clothing, flush with water or normal saline, use soap and water if only an oily substance. Otherwise, just flush with water is enough. But if it is an oily substance, you need to use soap and water. You need to use chemical neutralization agent, but can potentiate further injury. So using of chemically neutralizing agents should be preferably avoided, and corrosive injection agents injure skin and can have systemic effects also. So if the corrosive injections agents have come over your skin, that can cause some systemic effect also. So keep that these things in your mind. Coming to the eyes, very important, you need to remove the contact lenses. The if before you start washing the eyes, ask them to remove the contact lens if they have one. Flush copiously with water or normal saline. Use local anesthetic if required. Continuous irrigation until the pH is normal. You can use the litmus paper and just check what is the pH, and slit lamp and fluorescent examination. So when you have an ophthalmologist available, it's very easy. But if you don't have an ophthalmologist, this is the bare minimum that you need to do before the slit lamp and fluorescent examination. The other things you can do in any of the small medical setups. So decontamination of ingested poisoning, coming to the emesis. What is the present condition, whether we should encourage emesis or not? Generally, it is not recommended. So that is the first statement that I need to make. But there are some rare exceptions. So generally, it is not to be done. But rare exceptions are there. Attempt only in conscious alert patient. Mainly what we use is anti-emetic. Basically, what we use is emetics. Syrup of ipecac is one of the commonly described one, but there are alternatives not recommended at all. That is tickling the back of the throat, apomorphine, copper sulfate, and mustard powder. So if at all, very rarely, usually remember, we don't recommend this, but only in conscious alert patient. Otherwise, there is a chance of patient going into aspiration. So coming to the most controversial thing, gastric lavage, I am very sure you will have multiple views on gastric lavage, but this is what is the present position statement regarding gastric lavage or stomach wash, what we generally say. So indication, poisoning victims. So type of tube, very important, adult 30 to 40 French evolved tube or 30 gauge Jacques tube, child 16 to 28 French orogastric tube or Riles tube. This is what is normally recommended. And length of the tube to be inserted, adult should be 50 centimeter and children should be 25 centimeter. So the procedure in detail, lubricate inserting end with Vaseline or glycerin and pass it to a desired extent. Use a mouth gag. Pour 300 ml portion of water or saline at a time and 100 ml for a child and continue until returning fluid becomes clear. So that is what is a simple regarding gastric lavage. So these are the different types of tube what I have described, the classical evolved tube and the other tube what is described here. Precautions, the patient must be conscious, alert, and the patient should be sitting up. In unconscious patient, cuffed endotracheal intubation is important. He should be lying semi-prone on the left lateral side and the head should be dependent area. And lavage fluid, ideally warm water or saline or rarely oxidizing solution like potassium permanganate, tannic acid or iodinated water depending upon the solution. Like sodium thiosulfate, you go for 25% sodium thiosulfate for cyanide. Desfuroxamine 2 gram in 1 liter for water for iron injection and calcium gluconate for oxalic acid. So these are some not normally we don't do, but some general situation with the lavage fluid instead of warm water or saline, you can use these things. Complications as such, vomiting, aspiration, pneumonia, damage to the esophageal or gastric mucosa, rarely perforation. Where it is contraindicated in corrosive, convulsion for convulsions, ingestion, foreign body ingestion, petroleum distillate, esophageal varices, who are already having esophageal varices, it is contraindicated, and marked hypothermia. So these are the areas where we will not be advising to do an gastric lavage. And what is the current recommendation for this? I think the most important part of this lecture will be what are the recommendations for the use of gastric lavage. Must not be done as a routine measure. If at all it is indicated to be done, the following criteria must be satisfied. It is a confirmed case of ingested poisoning. It involves a deadly poisoning or deadly dose of a poisoning. It is not more than 2 to 3 hours since ingestion. I'll say maybe 2 hours will be the ideal, 2 hours since ingestion. Patient is fully conscious. The recommended tube is available. Trained personnel is available. And most importantly, airway is secured. Without this, don't attempt for a gastric lavage. So these are the minimum requisites, the criteria that must be satisfied that before you proceed for deciding for a patient to do a gastric lavage. So coming to the next one, the whole bowel irrigation, basically rapid administration of large volumes of osmotically balanced macrocol solution, polyethylene glycol solution, that is your PEG, what we commonly say, via an orogastric tube or an nasogastric tube, flush entirely into the GI tract. Indications, iron, lithium, sustained release formulation, body packer syndrome, endpoint, clear rectal effluent is coming out. Antibiotic may be required, contraindication, absent bound sounds or obstruction, complication, bloating, cramping, and rectal irritation. So that is your whole bowel irrigation and activated charcoal. When you ask me, previously there was a concept called as universal antidote but you don't have an universal antidote. Maybe you can call this fellow the activated charcoal. Basically, the appearance, it's a fine black, odorless, tasteless powder made from burning wood, coconut shell, or bone, followed by treatment with an activating agent. Resulting particles are extremely small but have extremely large surface area. 1 gram of activated charcoal will have 1000 meters square of surface area. And mode of action, it decreases absorption of various poisons by absorbing them on its surface. So that is a very important absorption and adsorption that you need to remember. And dose is 1 kilogram, 1 gram per kilogram body weight, usually 50 to 100 grams, 10 to 30 grams for a child. Procedure, you need to add 4 to 8 times the quantity of water to calculate a dose of activated charcoal, mix to produce a slurry sort of a suspension and ask the patient to drink it. So that is the recommendation. And overall, you should be giving poisoning due to amphetamines, tricyclic barbiturates, opiates, salicylates, strychnine, theophylline, quinine, etc. And ineffective against AHA, alcohol, heavy metals and acids. And disadvantages, it is unpleasant. Complication, you can have emesis, constipation, diarrhea, pulmonary aspiration, intestinal obstruction, and it is contraindicated in corrosives, petroleum distillate, and small bowel obstruction, and those who are having ill. So coming to catharsis, it is very simple. current recommendation not to be done, but just the sake of discussion, I have written here. You have different types of catharetics. You have contraindications. You can't use this, but current recommendation not to be done. So you can just remember it should be avoided. Enhanced elimination method, you have forced diuresis. What does it mean? Enhancing the rate of excretion of a poison or its metabolite by enhancing urinary flow. So basically where it is indicated. So it is indicated in poisoning in which poisons are mainly excreted in urine, mostly excreted unchanged, mainly distributed in extracellular fluid compartment and which are minimally protein bound. So you have alkaline diuresis, basically used for phenobarbital, salicylates, and lithium. So method is simple: 1,500 ml of fluid in the first hour. You have to add 500 ml of 5% dextrose, 500 ml of 1.4% soda bicarb, and 500 ml of 5% dextrose again. And you need to maintain a urinary pH of around 7.5 to 8.5 and maintain a urine flow of 500 ml per hour. Give furosemide if it is necessary. Add potassium to the IV fluid. Just you are trying to alkalize the urine, keeping a pH above 7.5 and between 7.5 and 8.5. And there is no acid diuresis. There is only alkaline diuresis. You can use with the help of our dextrose, 500 ml dextrose initially, then 500 ml of soda bicarb, then again 500 ml of 5% dextrose, and you need maintain a urine output at 500 ml per hour. Complication, you can have water intoxication, pulmonary edema, cerebral edema, electrolytes and acid-base imbalance, and it is contraindicated in shock, impaired renal function, and heart failure. Coming to extracorporeal elimination methods, so you should be remembering what are the common dialysable toxin. So that is a mnemonic. This is a mnemonic that all our VPLs have taught, and these are all from Sir's books only, whatever I am discussing here. So carbamazepine, salicylates, lithium, isoniazide, theophylline, caffeine, methanol, metformin, ethylene glycol, and barbiturate. So these are the dialysable toxins. And coming to hemoperfusible toxin, you have to remember carbamazepine, paraquat, phenytoin, theophylline, and barbiturates. So these are the common hemoperfusible toxins. And to conclude, what I just need to give you as a take-home message: always have a systematic approach. Majority of the time, stabilizing the airway breathing circulation will be more than enough, and conservative management will be more enough to save the patient. Always remember regarding various contraindications. So rather than doing further harm, you should be better not to do anything. And remember regarding co-ingestion, a chronic medication and associated medical conditions, decontamination for various methods. What are the different decontamination specifically for gastric lavage, and what are the various elimination process? And finally, the most important, airway breathing circulation management is the key aspect for your poison victim management as the general management, as the initial management. With that note, thank you for your listening. And if you have any questions, I'll be happy to answer those. Otherwise, I'll hand over to Dr. Shabrish, who will be taking you forward on antidotes.
Hi, sir. I'm Dr. Ranjit, sir. A
Yeah,
small
please.
doubt, sir.
Yeah.
Sir, regarding the dialysable toxins, sir, can
Yeah.
you go back to the slide, sir?
Yeah. Second.
The last third slides. The last.
Yeah. I'll just take. Yeah.
The next one, sir.
That is charcoal hemoperfusible.
Yeah. So routinely we do hemoperfusion with for the paraquat, sir.
Yes.
Is there any protocol for like what cartridge and what should be the dialysate and how much should we use or anything?
See,
like that,
again, once we get a paraquat poisoning, I think we have more to discuss on extracorporeal therapies. So extracorporeal therapies, again, coming to this hemoperfusible toxin. Paraquat, what we generally do is that as early as possible, go ahead and do the paraquat. For paraquat, you go ahead with the hemoperfusion, charcoal hemoperfusion. So majority of the time, the kit will be readily available. Usually your toxicology center, the kit will be readily available. You just call them and just do the routine charcoal hemoperfusion. I am not very much aware of the dialysate, the fluoride, etc. But I think Dr. Shabrish will be covering you that topic because he is the one who deals with the extracorporeal therapy. So this is what to my whatever we have been doing is regularly when we get paraquat as early as possible without delaying much. The renal failure, everything starts setting. we will go ahead and do the charcoal hemoperfusion. So, and Vinayak, if you have any additions or Doctor, you can go ahead and add on to this, because that is not my area of interest. So I haven't not explored that part, what we have asked me right now.
Yes, sir. As you mentioned, we usually go for charcoal-based cartridges, though resin-based cartridges are also available. But I think
Yeah.
the easiest ones to procure are probably either of them can be used. So
Yes.
the important thing is to maintain a high blood flow rate.
Yes.
Usually maintain a blood flow rate at least 300 to 400 ml per minute. We usually maintain. And the number of sessions required, usually, basically, we do this mostly for paraquat. The number of
Yeah.
sessions required depends on your, urinary paraquat levels when it
Levels,
turns
yes.
to be negative. So I think till then it is daily
Daily
treatment.
you need to continue. Yes.
Yeah, daily you
Yes.
need to continue till you get a negative.
Negative. Yeah.
Thank
So somebody was discussing there was 3 paraquat being admitted in
Yeah,
the
it's me,
hospital.
sir. It's me, sir.
Yeah. So how are they doing right now?
Sir, one patient is the creatinine level is improving, sir.
Okay.
The other patient started to have some chemical pneumonitis, sir. So I think I'll lose that patient for
Okay.
sure, sir.
Out
The
of
third
3, if
patient-
you're able to get 1, that is a great thing.
Yeah, third patient didn't consume much. He just took it in the mouth and he spit it out, sir. So he's going to come out, sir. That is almost stable patient, sir. I think he'll be out of it. But
Okay.
these 2 patients who have consumed less than 30 ml and I have initiated within 6 hours charcoal hemoperfusion, but still I have to wait for the results. How will they improve, sir? I think it will take some time to.
Just one more thing, as sir mentioned, time is of utmost essence here. If you're able to catch them early, say within the first 4 hours, then I think you can manage them well. More than 12 hours, I think it's a sinking ship. I think you
Yes.
have to tell a guarded prognosis and do it anyways. Yeah.
Yes. Shabrish, you have any comments on it?
No, nothing much. The only
Yeah.
thing will be about the interest in role of ECMO and all in paraquat. Probably we'll deal
Yeah,
with
we'll do that. I think we have a lot of discussions going on. I feel very happy because it's been very active in the first session. So this is the way, then it's going to be helpful for everyone, because whatever knowledge that you are having, and again, you have any cases that need to be discussed, you can just post in the group. Okay, I'm not. We are not just saying we don't want any regular good morning, good evening messages. But if you have anything related to toxicology, we are always welcome to discuss, because our guru VV sir will be there. So with this exposure and with this background, we will be able to give almost answers to what all questions that is unanswered. Okay, Shabrish, you can start off. I'll
Yeah,
make you as the co-host. Just give me a moment. Yeah.
Yeah, is the screen visible now?
Yes, it is visible.
Yeah. Okay. So that was a good start. Very, very elaborate and covering the salient points. Thanks, Krishna. And let us start with the session on antidotes. So I'll try to keep it brief, and because there's going to be a lot of specific antidotes which will be discussed in that specific poisoning scenarios. So this will be just to give you a quick overview. Give me a minute to just sort it out. Yep. So we'll start off with the question of what is an antidote. So for a definition's sake, you can say that an antidote is a substance that counteracts the effects of a poison. Simple, straightforward, basic English. It's a substance that counteracts the effects of a poison. And as Krishna told, we all are aware that we don't have antidotes for every toxins we are going to encounter. So hardly, if you name it, probably we are looking at a number just close to 5% is what we have antidotes for. That again emphasizes a lot on the general management in a poisoned victim. Now, there has been, during our UG days and all, there has been a lot of questions being asked on universal antidote. So what's the status of universal antidote now? Any opinion from anyone? Is there a universal antidote?
So there is no universal antidote, I think.
Okay, perfect. So, yeah, that's more or less the right answer. If you kind of try to search for a universal antidote in the Goldfrank's toxicological emergency textbook, you will have 12 hits. So, and all those 12 hits are under one chapter. That is the historical principles and perspectives. So, as Philosopher says, it is again just for the museums, this terminology, but it's important for us to know how this has evolved. So, the most of the mentions has been in the Greek and Roman literature, and in the Homer's Odyssey, you will see that Ulysses is advised to take moly. I mean, probably moly was supposed to be a cholinesterase inhibitor and was acting against Datura. Any guesses on what does the new slang moly means? In newer days, what is moly? Anybody from forensic? It's a slang used for MDMA now. Okay, right. We'll move on. Again, if you look at some Greek history, you will see that there is King Mithridates VI. So based on him, there was something called as Mithridium or Mithridate, which was supposed to be the universal antidote. And it's a very, very kind of interesting and funny story where this King Mithridate, he was kind of like very much having a phobia, or he was having this fear that he's going to be poisoned, and he used to take small doses of what he or his physicians felt that are antidotes, and kind of sensitized himself against that. And probably there was close to 72 plus toxins for which slow doses of antidotes he had been exposed to. And the legend goes that at the end, he wanted to commit suicide by him consuming something, and he was not able to die even after consuming a few poisons, and he had asked his guards to kind of kill him with a sword. So that again in Greek mythology you will find. From there, if you move forwards, then there is again the physician of Emperor Nero, the Andromachus, developing on the same antidote, and a lot of mentions about sacred earth and a lot of charms like snake stones and unicorn horns and beso stones, etc., acting as a universal antidote. So for all practical purpose, this is more for the historical dialogues only. But if at all, if somebody points a gun at you and say that, yes, there is a universal antidote, the closest bet would be something which Krishna has mentioned, like activated charcoal, which probably we are going to use for various toxicological scenarios. There are again certain other agents which can be used in a broader kind of multiple toxicological scenarios, would be bicarbonate and to a certain extent lipid emulsions. So these are going to be some agents which might come up as not specific antidotes, but more like an adjunct antidotes, which can be used against a few broader number of toxins. So is there a classification for antidotes? Yes, of course, yes. There is a well-known classification based upon the mechanism of action. So what are these mechanisms of actions? You have the inert complex formation, you have the accelerated detoxification, reduced toxic conversion, receptor site competition, receptor site blockade, and toxic effect bypass. Let's just see and understand what this is with examples for each. You have the inert complex formation, where the antidote forms an inert complex after combining with the poison, which is excreted. For some examples would be a chelating agent for heavy metals, ocean blue for thallium, and dicobalt ED88 for cyanide. So this is basically it's combining and then excreting it off. Then you can have an accelerated detoxification. So here, the antidote accelerates the detoxification of that specific poison. A good example would be thiosulfate, where it converts cyanide to non-toxic thiocyanate, and also probably N-acetylcysteine, which combines with the toxic metabolites of paracetamol and detoxificates them. So that is with 2. The number 3 is reduced toxic conversion. So here, the antidote reduces the toxicity by converting a poison to a less toxic or relatively non-toxic form. A good example would be your ethanol, which inhibits the metabolism of methanol by competing with the same enzyme. So we're done with 3. 4 is receptor site competition. Here, the antidote displaces the poison from a specific receptor site. And a good example would be naloxone, which displaces the opiates from specific receptor sites. Number 5 would be receptor site blockade. Here, the antidote blocks the poison from the specific receptor sites. And a good example would be atropine, which blocks the effect of anticholinesterase agents at the muscarinic receptor sites. And the last one is the toxic effect bypass. That is, the antidote exerts effects that help to bypass the toxicity of the poison. So here, 100% oxygen to bypass the toxicity of cyanide could be a reasonable example. So those are the 6 broad classifications under which you can club the various mechanism of actions. That is the inert complex formation, accelerated detoxification, reduced toxic conversion, receptor site competition, receptor site blockade, and toxic effect bypass. There can be certain antidotes which probably might share 1 or 2 mechanisms. For example, NAC, probably we can say that it uses, it would fall in the category of both accelerated detoxification and reduced toxic conversion, and ethanol likewise. So let us see what are specific antidotes and, as I mentioned, some adjunctive antidotes. Right. So most of it you've been knowing already, and just to enumerate them, and we will discuss them in detail in the respective classes. So you have paracetamol, you have NAC, N-acetylcysteine, you have the cyanide. If somebody asks you what's antidote, it could be nitrates, sodium thiosulfate, dicobalt TDT8, hydroxycobalamin, and dimethyl aminophenol. For datura, you have physostigmine, OP and carbamates. Of course, you have atropine, and definitely some role for oxines. You have oxalic acid for, you have calcium gluconate. For iron, you have desferrioxamine. For arsenic, you have British antilucide BAL. Lead, you have calcium disodium versenate. We will continue with the list for now. That is for copper. Penicillamine, you have diazepam, you have flumazenil. For methanol, we have, of course, as you all know, ethanol and formipazole if available. For beta blockers, you have glucagon, insulin, you have glucose. Opiates, the antidote would be, again, naloxone, isoniazid, pyridoxine, thallium, ocean blue. For warfarin, again, vitamin K and heparin, protamine sulfate. It's nice to know all of them, but at least the certain ones of a lot of practical significance which people will be encountering in our routine practice, we should all be aware of. And what are the certain adjunctal antidotes? For most poisons, as Krishna told, we gave whenever it is indicated activated charcoal. For general convulsant poisons, probably diazepam. Poison causing anaphylaxis, adrenaline. Poison causing psychosis, haloperidol. Methemoglobinemia, methylene blue. Any poison which is going to end up with metabolic acidosis, there is going to be some role of sodium bicarbonate, and for bronchoconstriction, salbutamol. So these are probably can be termed as adjunctal antidotes, but it's more of like the treatment of the effects of that specific poison. We will just quickly revise 10 commonly used antidotes for this session, but the details will be discussed in due course in the respective chapters. First one will be N-acetylcysteine. And anyone with clinical practice will be very much aware about the 2 protocols. That is your IV protocol and the oral protocol. You have the IV protocol where we give based upon the level of acetaminophen in the blood. Usually we look at the Rumac-Matthew nomogram, and it is in a significant level above what is acceptable. Then you start with an N-acetylcysteine IV infusion protocol, most likely. So the initial loading dose is 150 mg per kg IV over 15 to 60 minutes, followed by 50 mg per kg over 4 hours, followed by 100 mg per kg over 16 hours. We also have something called as a simplified 24 protocol, where you directly start with the 50 mg per kg per hour for 4 hours, followed by 6.25 mg per kg per hour for the next 16 hours. That will come to roughly around 200 mg per kg for 4 hours, followed by 100 mg per kg for 16 hours. So most of the times we prefer IV N-acetylcysteine over oral. Basically, we are not going to be, though if you look at the pure biomechanics or the pharmacokinetics of it, the effect is almost going to be same, but with the absorption and the patient having vomiting, etc., we usually stick on to the IV protocol and very not go for the oral protocol. If at all you want to know about the no protocol, you have a 72-hour protocol with a loading dose of 140 mg per kg per oral, followed by a maintenance dose of 4 hours after the loading dose. Start at 70 mg per kg per orally, Q 4th hourly, for a total of 17 doses. And there is also a lot of interest now in the STAP protocol, which again has a slight variation, where you give a loading dose of first infusion 100 mg per kg over 2 hours, followed by 200 mg per kg over 10 hours, and then an extended infusion, again, a dose of 200 mg per kg over 10 hours. This again is a weight-based dose. So that is with N-acetylcysteine. The other antidote which everyone should be aware of is atropine. As you know, it is indicated in OP or carbamate or nerve agent poisonings. The usual dose as per recommendation for mild to moderate is 1 to 2 mg bolus and repeat as needed. And the severe OP poisoning, it is 3 to 5 mg bolus. Repeat by doubling the dose every 3 to 5 minutes. The previous dose does not produce a response. And our aim is to maintain adequate atropinization by administering repeated doses as needed. After the desired response is achieved with IV boluses, we usually administer 10 to 20% of the infusion per hour. Here it is the bronchial secretions which you are going to be following. Right. So no absolute contraindication there. And adverse effects for should be monitoring are for agitation, anxiety, ataxia, behavioral changes, atrial arrhythmia, AF, MI, constipation, and urinary retention. Of course, one of the major issue which we face clinically is the atropine psychosis, which we need to deal with. Special precautions, of course, patients with history of MI, arrhythmia, glaucoma, thick bronchial secretions, hyperthyroidism, etc. should be a caution. Along with atropine is your praldoxine. Here, the indication again is for anticholinesterase overdose. The recommended dose is at 30 mg per kg loading dose, followed by 8 to 10 mg per kg per hour infusion. No specific contraindications, and the adverse events which are reported are pain at injection site, hypertension, tachycardia, drowsiness, paralysis, seizures, fasciculations, apnea, and renal insufficiency. And of course, there are certain special precautions mentioned in cases with known case of myasthenia gravis. Carbamate poisoning, of course, it is of no role, and patients with renal impairment to use with caution. So that is, we are done with our NAC, atropine, and praldoxine. Now with naloxone. Naloxone, as you all know, is indicated in opioid overdose or toxicity, and also in clonidine toxicity. The recommended dose, yes, it is 0.1 to 0.4 milligrams IV, and 0.4 to 0.8 mg IM, or 0.8 mg sub-Q, or 4 to 8 mg intranasally. So basically, you have an IV dose, which we usually follow. That is, remember the dose as 0.1 to 0.4 mg. Right. So the contraindication, of course, the absolute contraindication will be hypersensitivity, and the other adverse effects which one should be looking forward are ventricular tachycardia, ventricular fibrillation, hypertension, tachycardia, abdominal pain, and also certain neurological symptoms. And special precaution should be taken in patients who might have symptoms secondary to opioid withdrawal. So coronary artery disease, people with coronary artery disease might develop hypotension, pulmonary edema, and arrhythmia. So basically, you have a person with opioid, naloxone is going to be your antidote. Yes, again, sodium bicarbonate, as I told, it's not just for a specific kind of toxin, but in situations where there is severe metabolic acidosis, hyperkalemia, those kind of situations also, it can definitely have a role. A specific indication would be a TCA overdose or a salicylate overdose or methanol toxicity, where the usual recommended empirical dose would be 1 to 2 milliequivalents per kg. IV bolus followed by 2 milliequivalents per kg per hour IV infusion in 1 liter 5% dextrose, and titrate to target a urine pH of 7.5 to 8.5. An absolute contraindication, probably in life-saving situations, we are anyway going to use it. Uncorrected hypokalemia should be used with caution. Adverse effects, of course, watch for hypokalemia, volume overload, alkalemia, hypocalcemia, any IC bleed, and intracellular acidosis. And also special precautions, chloride loss due to vomiting and from GI suction, diuretic-induced hypochloremic alkalosis. So these kind of situations, probably you need to be cautious. But again, as I said, these are going to be desperate situations where we will be thinking about soda bicarb. Right. Regarding activated charcoal, again, Krishna mentioned about activated charcoal in his presentation itself. As you know, it is indicated in injection of toxic substances, ideally within 1 hour, or not anyway, definitely more than 2 hours. And when you are sure that the toxin is known to be absorbed by activated charcoal, there is some role for multi-dose activated charcoal also. So the usual recommended dose for a single dose is 25 to 100 grams single dose, and if at all we are going for a multi-dose activated charcoal, it is usually 25 to 50 grams Q4th hourly. Contraindication, of course, non-toxic injections, probably there's no role. Unprotected airway, use with caution. Of course, corrosive injection because of the possibility of upper GI perforations. Definitely, we are not going to use activated charcoal in corrosive injections. Adverse events, yes, vomiting, constipation, fecal decoloration, aspiration of activated charcoal, and impaired absorption of orally administered antidotes. Again, as you remember, if you're giving activated charcoal, probably we may not be able to administer other antidotes per orally. And special precautions, give via Ryle's tube with fruit juice if whenever possible, and account for the risk of vomiting and decreased peristalsis. And airway protection, of course, needs to be given a priority when GCS is low. The other thing will be to know about GI bolus or the glucose insulin infusion. So you have the calcium channel blockers and beta blockers overdose where we can consider glucose insulin infusion, where it is a high dose insulin therapy with a bolus of 1 unit per kg of regular short acting insulin, which is given IV, continuous infusion at 0.5 units per kg per hour, and titrate upwards till hypotension is corrected or a maximum dose of 10 units per kg per hour is reached. So euglycemia can be maintained by means of continuous IV infusion of 5 to 10% dextrose. Of course, 50% if needed. And since we are giving insulin, we need to have a monitoring over the potassium also. So here, it is basically the insulin which is acting, and to prevent hypoglycemia, we're continuing with the dextrose infusions. No specific contraindications, and the adverse events to watch out for will be fluid overload, hyperglycemia, and special precautions. Yeah. Moving on to one of the last, that is flumazenil. Because if you have a person with a suspect, a very, very strong indication of benzodiazepine overdose, you're going to fall back on flumazenil. The recommended dose is 0.2 mg IV over 2 minutes. If the desired level of consciousness is not obtained within 30 seconds after the first dose, 0.3 mg can be administered after 3 minutes. And if the desired level of consciousness is still not obtained, a third dose of 0.5 mg can be administered over 5 minutes and repeated at 1 minute intervals. So basically, you have a suspicion, you give the first dose, no improvement, probably at you're going to repeat another dose, 0.3 over 3 minutes, no improvement, 0.5 over 5 minutes, and at 1 minute again, non-mg. So, but remember that the usual cumulative dose to say that the person is not responding would be around 3 mg. So that is with flumazenil, but remember that the use of flumazenil has been associated with occurrence of seizures. Basically, you're nullifying the effect of benzodiazepine, and the patient might throw seizures. And contraindication, hypersensitivity to flumazenil, of course, and the patients administered benzodiazepine for control of potentially life-threatening conditions. So where you have a raised ICP, or we definitely need the patient on benzodiazepines, those kind of indications, probably we should not be venturing into flumazenil. And also in people who may have ingested or are showing signs of cyclic antidepressant overdose. Again, there we are not going to fall back on flumazenil. Adverse effects, of course, as we discussed, seizures, anxiety, insomnia, pain at the injection site, and palpitations, and special precautions. Yes, flumazenil, again, the person might just wake up and immediately after a few minutes can go back to sedation because of the residual benzodiazepine effect. And the last one is methylene blue. You have methylene blue, which is indicated in oxidizing toxins, that is for nitrates, benzocaine, sulfonamides, and moreover in patients who are presenting with methemoglobinemia. The recommended dose is 1.2 milligrams per kg IV and a repeat dose after 1 hour. And in neonates, the dose is 0.3 to 1 milligram per IV. And here the contraindications of clinical relevance is G6PD deficiency and also pregnancy. And for adverse events, you watch out for dizziness, urine discoloration, etc. And special precaution, of course, you have to avoid extravasation. And moreover, remember that the patients whom we administer methylene blue over will kind of have a bluish tinge over their skin, and the complexion might turn not exactly blue, but dark bluish, blackish kind of discoloration can happen. So that the relatives should be cautioned regarding the same. So with that, I will kind of end the session. So we did discuss about the basic concept of what is antidote, and also we discussed the various mechanisms in which various antidotes acts, and also we had a quick look at the certain toxins and what are the specific antidotes for each. And also some of the commonly used antidotes. We picked kind of 10 from the huge list, and we kind of quickly gave a one-pager of what is the basic action, what is the contraindication, what is the usual dose, what are things you need to be aware of. So with that, I will conclude, but definitely we will have detailed sessions in the specific classes. Okay, thank you. Over to Krishna.
Thank you, Shabrish, for that session. I hope we don't have any queries. So with that in background, we'll go to the third session. It is my privilege and pleasure to invite my teacher, both of our teacher basically, Giri sir, for the third session on ECG in toxicology. So over to Giri sir.
Good afternoon to all. So, next 20 minutes, I'll be talking about ECG in non-cardiac conditions and toxicology. The original topic was ECG in toxicology. That's a very short topic, and it may have only 5 or 6 slides. So I thought I'll incorporate this condition also. Non-cardiac conditions and toxicology. You may be knowing many of the toxins can produce electrolyte imbalances and other problems. So that ECG also may be useful for all of you. So first of all, one of the most common conditions what we face in emergency room is hyperkalemia. Many toxins also can induce hyperkalemia. Many conditions that produces rigidity, spasticity in patients, that also can induce hyperkalemia. But one of the most common condition which can present with hyperkalemia is renal failure. So whether it is an acute renal failure induced by toxins or induced by some infections or whatever it is, since the topic is ECG changes in non-cardiac emergencies, hyperkalemia is one of the most common cause for ECG change. Depending on the serum levels of potassium, you can get various changes. I'll show the ECG in the next slide. You can get very tall peak T waves. That is one of the classical finding what you see in hyperkalemia. If you see the tall T waves in most of the leads, whereas in hyperacute myocardial infarction, you can see very tall hyperacute T waves in V1, V2, V3, V4 in acute myocardial infarction of anterior wall, and inferior wall 2, 3 AVF you can get. But if you are seeing very tall peak T waves universally, most of the leads, then you have to suspect hyperkalemia. And another important problem what we are going to see in hyperkalemia is bradycardia. These two important signs you should remember: very tall T waves in most of the leads and bradycardia in a patient who is having suspected renal failure. That we have to, in that condition, we have to think about hyperkalemia. There are a lot of other changes also can happen in hyperkalemia. I will show the ECG. Here in hyperkalemia, what you are classically finding is very tall T waves. You can see here the T waves are very prominent, very tall, tended T waves are the classical finding of hyperkalemia. You can see here the QRS complex will become widened then. Okay, and it will become something like a sine wave pattern. Okay, that is also a very classical sign. But what you should remember is in a patient with hyperkalemia, bradycardia and tall T waves always indicates significant hyperkalemia. But depending on the level of potassium, you can get various changes. Whenever you are seeing ECG changes in a patient with suspected hyperkalemia or patient with renal failure, you have to treat the patient. So in chronic renal failure, many patients can have mild hyperkalemia. You may not give a emergency treatment, but you need to give a long-term prevention treatment to prevent hyperkalemia. So very tall T waves and like wide QRS complex, sine wave pattern is the classical finding. However, in a renal failure patient, if he comes with bradycardia, that will be an indirect sign of hyperkalemia. Now, hypokalemia also can produce ECG changes. You can see the classical ECG change in hypokalemia is U wave. U wave is a wave formed after the T wave. You can see in V2, V3, V4. That is mainly anterior leads, or V3, V4 is the classical leads where you get U waves. So that will be the classical finding of hypokalemia. But you can also get ST depression, T wave flattening, or inversion. All these things in hypokalemia also. P wave can be larger and wider. So notch can be there in between P wave. PR interval may prolong slightly. Low voltage complex also seen. But the classical finding of hypokalemia is U wave. I'll show the ECG. So this is the U wave. You can see here there is P wave, QRS complex, ST depression, then prominent U wave. Okay, so prominent U waves are classically seen in V2, V3, V4. Okay, that is in the anterior leads. So in any patient who is having acute weakness, muscle weakness, and if you are seeing potassium levels are low, and look for ECG changes like U wave. U wave is a classical finding seen in ECG because of hypokalemia. I'm not mentioning the treatment here. I'm only discussing the ECG changes. And calcium disorders, most of the patients with hypocalcemia and hypercalcemia, you can get QT interval alteration. Hypocalcemia produces a long QT and hypercalcemia produces a very short QT. These two things you should remember. Hypo produces long and hyper produces short QT interval. But what is the problem because of this hypo or hypercalcemia? This can produce ventricular arrhythmias. Both the conditions can produce ventricular arrhythmias. That is very important. Long QT or short QT will not have any clinical implication. That means it will not alter your clinical management. But you should remember that there are certain drugs. Already QT is prolonged. There are some drugs which also can produce QT prolongation or QT shortening and produces arrhythmias. Some of the toxic material, like some of the drug toxicity also, you can get similar finding that I'll explain afterwards. So hypocalcemia and hypocalcemia and hypercalcemia both can produce QT interval alteration. Now, hypomagnesemia is another important condition where many of the patients who are admitted in ICU due to various reasons, including toxicological patients, urinary tract infection, diabetes, so many other conditions, malignancies, you can get hypomagnesemia. ECG changes also can occur in hypomagnesemia. You can get ST depression, tall peak T waves, flat U waves, flat T waves, U waves, loss of QRS voltage, VR prolongation, widened QRS complex, QT prolongation. So many ECG abnormalities you can see in hypomagnesemia also. So all this electrolyte imbalance you can expect in a patient who is admitted in ICU. So most of the electrolyte imbalance can have similar findings. Now, another important non-cardiac condition which can produce significant ECG changes, pulmonary embolism. Any patient come with acute onset of breathlessness due to whatever reason, you have to take an ECG. Most of the conditions like COPD, asthma and all, you can get only tachycardia. But pulmonary embolism is one condition where you can get some classical findings. I'm not telling all these classical findings will be there in all the patients, but there are some patients, a subset of patients, you can get all these findings very prominently. Sinus tachycardia is the most common finding of pulmonary embolism. Right axis deviation, right ventricular hypertrophy, both you can see in some of the patients. Right bundle branch block can be seen in some of the patients. Atrial fibrillation is one of the classical atrial arrhythmias seen in hypoxemia or any condition which can induce hypoxemia, including pulmonary embolism. S1, Q3, T3. That means you can see here S wave in lead 2, S1, lead 1. Q3 is Q wave in lead 3 and T wave inversion in lead 3, S1, Q3, T3. This is a classical finding of pulmonary embolism, but you don't see this finding very often. Very rarely you can get this type of findings. But that is a classical condition. Now, COPD also can produce some of the ECG changes. One is a very prominent P waves in the ECG that is called as P pulmonale. Then right ventricular hypertrophy, very prominent R waves in V1 and multifocal atrial tachycardia. What is multifocal atrial tachycardia? Here you can see the P wave morphology is varying. So here P wave is very prominent and it is very sharp, whereas here P waves are inverted. Here you can see P waves are inverted. P waves are inverted, very sharp, blunt P wave, and P wave is blunt here. So the various types of P waves are seen in multifocal atrial tachycardia. This is classically seen in hypoxemia. One of the classical conditions which can produce multifocal atrial tachycardia because of hypoxemia is COPD. COPD with acute exacerbation. Now we'll discuss about ECG in toxicology. Many of the toxins or drug overdoses, you can get various degrees of heart blocks or various types of ECG changes. And what we have discussed previously is electrolyte imbalance. Many of the toxins can induce electrolyte imbalances in your ICU directly or indirectly, and that also can produce problems in ICU. Now, fast sodium channel blocking drugs. So I'll tell you what are the drugs which comes in this category. Some of the drugs are very commonly used drugs. They can produce ECG changes like very wide QRS complex. If you see the QRS complex, normally the width of the QRS complex will be less than 3 small squares in ECG. But if it is wider than 3 small squares, then you have to tell it is wide QRS complex. Right axis deviation in dermal QRS and bradycardia, some of the patients can develop ventricular tachycardia and ventricular fibrillation. So wide QRS complex can slowly lead to ventricular fibrillation. Some of the patients can present with bradycardia. So we'll see what are the drugs come under this category. One of the most common drug what we use in peripheral neuropathy, migraine or depression is amitriptyline. Amitriptyline, desipramine, dothipin, imipramine, nortriptyline. All these drugs are very commonly used drugs and that can produce arrhythmias. And class 1 anti-dysarrhythmic drugs. At the same time, when we are calling it is dysarrhythmic or anti-arrhythmic drugs, they are all pro-arrhythmic drugs. When we are using these drugs for a long period due to some reason, if the drug levels are going high because of renal failure or something or drug overdose, they can develop arrhythmias. So same time when they are anti-arrhythmic drugs, they are also pro-arrhythmic drugs. No, encanide, flecainide also can produce this type of problem. Bupivacaine, cocaine, ropivacaine. In that, cocaine is used nowadays as recreational drugs. So many of the patients can develop this problem. They can present with ventricular tachyarrhythmias. Anti-malarial drugs, nowadays we are not using these drugs very commonly. Quinine infusion can produce Torsades D points and it can also produce ventricular arrhythmia. Amantadine, it's a drug used in Parkinsonism. Diltiazem, propranolol, they're all antiarrhythmic drugs. They can also produce dysarrhythmia. Diphenhydramine is a very useful drug which is used in dry cough that also can produce sometimes arrhythmias. Carbamazepine used in seizures. Then some other drugs also can produce problem. Blockage of sodium channel leads to delay in fast influx of sodium. This represents by a large pronounced drop on the phase 0. You can see here phase 0 is increased. Normally it is vertical, but it is shifted here. The greater degree of blockage, the wider the result of QRS complex. You can see when it is straight, the QRS complex will be narrow. When it is slightly delayed, you can see the QRS complex is becoming slowly wider. That is a problem. Slowly, this patient can develop a wide complex tachyarrhythmias like ventricular tachyarrhythmia, ventricular VT, ventricular tachycardia. Another important finding is AVR positivity. Normally, when you are seeing a ECG, a normal ECG, you may be knowing that all the complexes in AVR, that is a right-oriented leads, since the electrical activity is away from that vector, all the complexes in AVR will be negative. P wave will be negative, QRS complex will be negative, ST segment will be negative, T wave will be negative in AVR. If AVR is positive, there may be some reason for that. One of the reason is this type of sodium channel blockage drug overdose. So ABR positivity is a very classical finding in any suspected toxicological cases. Suppose you see a patient with amitriptyline overdose, you have to first see the ECG, whether there is a wide QRS complex, whether there is a tachycardia. Before all these things, you should check the ABR. Since normal ECG shows everything is negative, you will not miss this finding. So if it is positive, there are very selected, very few conditions which can produce positivity in AVR. One of the condition is drug overdose. Now you can see here, look at this ECG. One of the classical finding what we have discussed, positive waves in AVR. That is a finding seen in amitriptyline overdose. So here the ECG shows 1 millivolt and 25 milliseconds is the speed. Here you can see red arrow shows leads 1 AVL and yellow arrow is AVR. That's what we discussed. AVR shows prominent positive waves. Is a classical finding of amitriptyline overdose. And QRS complex generally you can see here QRS complex is wider. The QRS complex, you just see this this QRS alone. It starts from here. It at least takes 5 small square. The QRS ends here. So 4 small squares. If it is less than 3 small squares, it is normal. If it is more than 3 small squares, it is wide. So here QRS complex is wide and there is a prominent positive wave in AVR. These two findings are important findings which is seen in possible amitriptyline overdose. This is a ECG of amitriptyline overdose case. Potassium efflux blockers, again, that also can produce lot of finding. You can get again wide QRS complex. QTC is prolonged. Here, what you are seeing is a normal QT here. From Q to T, end of the T, there is a normal QT QT segment. But here, what you are seeing a prolonged QT interval. It's a very prolonged QT interval. So you can calculate the QT interval if you want, but most of the newer ECGs tell you what is the QTC of that patient. The problem is after prolongation of this QT interval, suddenly this patient develops ventricular arrhythmia. That means a wide complex QRS, wide QRS complex tachyarrhythmia. But you can see here what is happening. The QRS complex is going up initially, then slowly it is going down. It is going towards the negative axis. Again, it is coming back to the positive axis. So this is twisting around this normal axis. This is called as Torsades D point. So that is a classical finding what you are seeing in potassium efflux blockers. Now see what are the potassium efflux blockers and see which all drugs are very common in your practice. So here you can see haloperidol is one of the common drugs we use in agitation. Chlorpromazine is one of the important drug we use. Quetiapine we use in many patients. Olanzapine we use in many patients. So all these antipsychotic drugs has got a important pro-arrhythmic property. Again, quinidine, nowadays we are not using quinidine, but you should know about this. And encainide and flecainide, both these drugs are anti-arrhythmic drugs. At the same time, they are pro-arrhythmic drugs also. Sotalol, amiodarone is a very useful anti-arrhythmic drugs, but it can also produce this type of problem. Tricyclic antidepressant, that's very commonly used antidepressive medicine, and it is also used in peripheral neuropathy. Amitriptyline, desipramine, dothapine, imipramine, all these things, they also can produce this type of problem. Citalopram is a drug. Escitalopram and citalopram both are used in depression, especially in elderly individual. These drugs can produce arrhythmias, but basically escitalopram is a safer drug than citalopram or any other tricyclic antidepressant. Antihistamines, again, diphenhydramine is a very commonly used cough suppressant. Most of the cough syrups you can get, you can see this content. So that also can produce arrhythmia. Then loratadine is like a drug used in allergy. Terfenadine, again, these drugs all can produce arrhythmias. Chloroquine and quinine both can produce this problem. One of the antibiotic which very rarely produces arrhythmia is erythromycin. Nowadays, we are not using erythromycin, but we still use azithromycin, clarithromycin. So as a group, they all have similar properties. Delayed potassium efflux prolongs the action potential. You can see here the picture. That is a dotted line. and it can produce QT prolongation. So since the dotted line is prolonged, the QT also get prolonged. Now, potassium efflux blockers, we have seen what are the drugs. You can see here QTC is prolonged. From the Q to end of the T, it is prolonged. Just simply see this, if the T ends after the, half the way of 2 bracket QRS complex, you should think that there is prolongation of QT interval. But most of the newer ECGs will tell what is the QTC of that patient. You can see whether it is prolonged or normal. Now, what is the problem if the QT is prolonged? That is very important. When the QT is short or QT is prolonged, the patient can develop ventricular arrhythmias. One of the classical ventricular arrhythmia you see in QT prolongation is Torsades de Pointes. So what is Torsades de Pointes? That is also very important. So you look at these QRS complexes, they are wide. When they are wide, normally it will be in the same axis. So QRS complex will be either positive or negative. But here what is happening, QRS complex axis is going up, then down, then up, then down, then up, then down, then up. That is the axis is twisting around the baseline. So that is a classical finding of Torsades de Pointes. Normally the treatment of Torsades de Pointes is magnesium sulfate. Now, tricyclic antidepressant, because since it is the large, its use is larger than any other antipsychotic drugs, we should know about this. The classical findings are QRS complex is wider and you get a prominent R wave in AVR. So I have already told that normally in all the in AVR, all the complexes will be negative. P wave will be negative, QRS will be negative, T wave will be negative. Everything will be negative in AVR because the electricity from the heart goes away from that vector, right hand. So you get everything negative. But when you're suspecting a toxicology case and AVR is positive, you have to think about this type of drug toxicity, especially tricyclic antidepressant. Now you can see here the ECG finding very prominent R waves in AVR. That is a classical finding. You should not forget this because very rarely you get a positive wave in AVR. Most of the conditions, whatever may be the condition, AVR will be negative. Very rarely some types of myocardial infarction or ECG late misplacement or in tricyclic antidepressant toxicity you get. And you can see here wide QRS complex. The problem of this is suddenly this patient can go to ventricular tachycardia. In ACLS, we call it as wide complex tachycardia. Wide complex tachycardia. Now, cardiac glycoside toxicity, there are few drugs and few toxins. The commonly used drug is digoxin, and the common poisoning is cerebroodolum toxicity. You may be knowing digoxin we are using in patients with cardiac failure with atrial fibrillation. That can reduce the heart rate, that can increase the pumping of the ventricular pumping of the heart. But there are some electrolyte imbalance like hypomagnesemia, phosphatemia. All these things can be associated with digoxin toxicity. Or if the patient is having renal failure, if you don't reduce the dose of the digoxin, again, that also can sometimes produce digoxin toxicity. Or if the patient takes large quantity of digoxin tablets with a suicide intention, then also patient can develop digoxin toxicity. So you know that it is going to reduce the heart rate. So when there is an overdose, a patient can develop severe, significant bradycardia or heart blocks. It can produce first degree to third degree heart blocks. Second degree onwards, patient can have symptoms also. Now, digoxin toxicity and digoxin effects both are entirely different. Digoxin effect is, here you can see this is a normal T wave. Here you can see the ST depression and T wave inversion. In a patient who is on digoxin, this is called as Salvador Dali sagging appearance or reverse tick sign. Reverse tick sign. Okay, so that's a classical finding of digoxin in ECG. This is not digoxin toxicity. Digoxin toxicity means patient develops various type of arrhythmias, flat and short QT interval, PR prolongation, prominent U waves, terminal portion of T waves will be peaked, and J point will be elevated. Most of these effects are initial effects of digoxin toxicity, or sometimes you can call it as digoxin effect only. And that classical finding is the Salvador Dali sagging sign. So when there is an overdose, you can see many patients come with severe bradycardia and heart blocks. ECG finding of digoxin toxicity, if you see the standard textbooks, almost all types of arrhythmias are common in digoxin toxicity. But the prominent findings are always you get AV blocks, first degree AV block, second degree AV block, third degree AV block. Remember, these findings are very classical or very very prominently seen in patients with renal failure. Patient is on digoxin with the renal failure, the clearance will come down and patient can develop a lot of arrhythmias because of digoxin toxicity. Or if the patient takes digoxin continuously for 7 days, normally we give 5/7, 5 days by 7 days. So if they take continuously also, sometimes they can develop. Or if the patient is having electrolyte imbalance like magnesium defect or phosphorus defect, there also you can get these type of problems. But what you should remember is, since digoxin reduces the heart rate normally itself, this toxicity can produce severe bradycardia, symptomatic bradycardia with heart blocks. Now, the odalam poisoning also, you can get similar finding. I didn't discuss that. Cerebral odalam is one of the classical poison we see in our area that also can produce severe heart blocks, and sometimes we may have to pace the patient. Now, cardiac toxicity of Neria oleander. Oleander toxicity is also very common nowadays. And they also, oleander contains cardiac glycosides, including the roots and the smoke produced from burning. So that can also have similar finding what we have discussed. They can have positive inotropic and negative chronotropic. So pumping increases and heart rate decreases. So similar finding you can get there also. In Datura poison, it's just opposite of what we had discussed. It can have some other additional finding. It contains something, the drug like something like the drug atropine. So atropa belladonna, that can produce tachycardia. So it is like atropine toxicity. Patient can have altered behavior. Patient can have tachycardia and prolonged QT interval. Okay, so the all parts of the plant contain tropane alkaloids such as atropine, hyoscyamin, and scopolamine. All will have similar finding. So atropine, when we are treating OP poisoning with atropine, you can see atropine toxicity finding, like patient will be agitated, patient have tachycardia, patient have dilated pupil, patient have decreased secretion, and heart rate is one of the classical finding. You can get very high heart rate. Now, antihypertensive toxicity, it is not very common, but you can get some patients with toxicity of antihypertensive, especially when they have renal failure. If they have taken higher doses of calcium channel blockers or beta blockers, that also can produce severe bradycardia, heart blocks, and conduction defects, all these things. So they are also classically seen in patients with renal failure, or intentionally if patient takes larger amount of calcium channel blockers, especially diltiazem or verapamil, and beta blockers also can produce bradycardia. One of the problem in renal failure, when the patient is taken larger dose of beta blocker in a patient with renal failure, they can have some patients of renal failure also can have hyperkalemia. So that is called as BRASH syndrome. Patient with beta blocker overdose, renal failure with hyperkalemia, they can have severe bradycardia, severe ECG changes, heart blocks, all these things. So some of the recreational drugs like amphetamine and cocaine also can produce severe dysarrhythmias, ventricular tachycardias, hypertension, coronary artery disease, coronary vasospasm, acute myocardial infarction, stroke-like features. All these things are possible in recreational drug overdose. Classical ECG finding will be tachycardia. Some of the patients can have ST elevation with TO inversion or acute myocardial infarction or ischemia features. So we have discussed about most of the toxin-induced ECG changes and some of the electrolyte imbalances in your ICU, which can be produced by toxins or like patients admitted with with some history of toxemia can also have similar findings. Thank you.
Thank you, sir. If you have any questions, we'll be happy to answer those. Yeah.
We'll inform it.
Program.
It triggered.
So if you have any queries, we'll answer those. Okay, fine.
Okay.
Thank you, sir.
Okay, thank you all.
So, thank you all for attending the session. So just a moment, I will take the attendance now also. So our attendance for the day. Okay. So, you have any queries regarding our program? Anything that you can just unmute yourself and we can discuss. We have another 5 to 10 minutes more. So stop the recording.